So I'm going to do a boring case after that. How do you follow that? So basically, this is a case I did Wednesday night before coming here. Um, so this is a 75-year-old male, CHAD score of 5. He had, for age, hypertension, diabetes, had his prior stroke. He had thrombus in his left atrial appendage on Coumadin. He was then changed to Pradaxa. Had nightmares, which I've never heard of, but I was doing this case with one of my former fellows.
No, we used to get nightmares.
So,
before the ablation.
So basically took him off of that, and he has renal insufficiency, so he's been on renal doses of Xarelto, but he's continued to have some bleeding. So, so I think this is a very reasonable candidate for the Lariat procedure. The real question here is, this is the actual lateral view and the LAO view. This is CTs, and this is the appendage. And the real question is should this even be done? All right?
That looks like a double black diamond there.
Yeah, I mean, this is the thing. So, what you're seeing here, he has a posterior lobe, he has an anterior lobe, and then he has a very long finger projection. And if you look in the LAO view, anteriorly, normally you'd want to have your magnet wire up in here, but then you see how far posterior this goes. Then we actually looked at the size of this. So from this yellow dot to here, it wasn't that long. It was only 3 centimeters. And essentially from here to here, the widest part was only 3 centimeters. It was really this part here that if you actually came towards, the anterior part, remember, is up here, is this way, it was 5 centimeters. So at this time, this was the patient. I hadn't looked at the CT until I got there. And I really said, you sure you want to do this? I said, I think you should talk to your patient and really say that there's a high likelihood you may not be able to capture this. The other thing, what concerned me is that you can see this part right here, it goes backwards, and you have to take your lariat and go all the way over. One of the questions is that could you even get it over, because this is a cutaway and the pulmonary vein sits right there. So you may not even be able to get it to go there to try to get at, your best closure would be here, and you actually may end up here. And if so, have you done the patient any good? All right, and that was really the other question. The other thing is say if you were able to get it all the way over, would you be able to get the lariat off? Because by the time you get over here, close it down, you're actually pulling down on the appendage. So it was all these factors, and I said, if you want to talk to the patient, just tell him there may be a chance that he may have to go to surgery or we'd fail. And then we actually looked at other options, and one of the options was the ACP plug, because they do that there. And because he was on Xarelto, he wasn't a candidate. In terms of surgery, could you actually put a clip and get there? You couldn't put a clip going this way because the pulmonary vein is there. So the best the clip would do would be to come down this way too. So, I talked to Seibel and, asked him, is this a thing for the Watchman? And, Seibel, everything's possible. Obviously it was.
What did you do? Sure. I'm biased. I'm crazy, but what about you?
I mean, unfortunately, like I said, I did this case right before I got on the plane, so I wasn't able to gather all the echoes. And that is probably what you guys would need, is the actual depth. What would be the depth.
But I just think that there's a neck, and I think 90% of you, a Watchman would be okay with it.
Yeah. However, the real question is even if you were able to get a Watchman in, you can see here, there is no low.
Did you have an endocardial view of the ostium?
You had a T to it. Don't you have a T?
I have one T view down at the end. Yeah, and we could actually talk about that after. I mean, because like I said, I was walking out, so I didn't have time to grab all the images and everything. Yeah. But I mean, that's a possibility, would be the Watchman. My concern would be even with the Watchman, would you be able to cover all of this? So after he talked to the patient, after about, whatever discussion he had, the patient wanted to go forward. because he really thought that, hey, if you guys can't do it, then we'll have to explore other options. So, as I was saying, as, DJ pointed out and, Matt talked about it earlier, is usually you want to get the magnet to the most anterior aspect, and, here's the sternum would be on this side. But if, you actually try to go too far down, then you're really, going posteriorly. So really the objective was to get the wire there. Which way is it? There we go. Nope, sorry, going the wrong way. And this is just a blown up view, in terms of what we're up against. So what we did is we did, basically put a pigtail catheter in here and really illuminated the left atrial appendage. And even with a pigtail catheter in here, we still did not get complete opacification of this whole thing. But you can see this just goes here. Here's a, well, the movie won't play, but it's all right. Can we go to the next slide? It's stuck. Okay, so this is the LAO and RAO, and I just put these in, these CT. Here's, because you see here, this is filling, so it's filling this. But in the LAO view, you can see right here, the catheter is actually pointed anteriorly because you could see the sheath is directed at us. If it was directed to the right, it'd be posterior. And you can see here, there's only partial filling of this long finger that goes all the way down there. And this part right here is that inferior or posterior lobe. So this part right here is this part right here in terms of going over. And what we did is we actually really deep-seated this because basically we're trying to get it to get down to here. But basically we just said, looking at that, if we would have gone down there, we would have been way over here. And we thought that because of the size of this finger, that the lariat wouldn't go from here to there. So we actually left it up there to try to encompass that. And, this is just, again, the symmetry, what we were talking about. But here is where we really took it, because this is the angle that we had. So the magnet is right up here, and this is the link. And what we had to do with this, and this is where access was everything, and this is, again, where pre-planning, what we were talking about, is knowing the anatomy, and then, as Matt alluded to, where do you do your pericardial access? In this case, you couldn't go too lateral because you had the anterior. So we actually just went a normal place, but we did it so that we could really rotate. And you can see how posterior we rotated this thing. And we did it to the point where this lariat is almost, not upside down, but really turned over. And we tried to go right over there with that. And actually, once we got to that point, it went over very smoothly, much easier than I thought. Because I thought what we were going to do was just push this nose of the tip of the appendage and just have it prolapse over. But it actually didn't do that. So what we were faced with is this is the echo view, and this is that inferior portion. You can see how it's a pocket right there. And normally you would just close right here, and you would leave this whole pocket, and that's that inferior posterior lobe. So what we did is we put the balloon, blew it up.
I guess, can I make a comment over here?
Yeah.
You see, that would not happen. See, look at the device face will be perpendicular to the trajectory of the sheath. Right?
The device face, your device.
Yes, any endovascular device.
Yeah, okay.
So when you advance the sheath from there, it would go to the anterosuperior lobe, not that one, the other one. Actually, that's the lobe which on the right side of the screen.
This.
No, yes, yeah, that's right.
Yeah.
So the device would therefore be angled in such a way it would be a little bit in the pouch.
It would be this way.
Yes.
Right. Yeah. Oh. So do you think you would be able, see, this is, this is unfortunate. We don't have all the echo views, because then, these guys to my left could really assess how well that they could close this off. Because I was actually contemplating even, putting it there, you still will have this section left.
Yeah.
Right. And that's the thing. You would have that. So what we did is, to try to actually capture this whole thing, we actually inflated the balloon, and I don't have this image, and we inflated the balloon in this pocket.
Pushed it further.
Yeah. And What?
And then went above that.
And we went above it and we closed on it and had the balloon hold the lariat so that we're on the atrial side of this. And unfortunately, wait a minute, going this way, I don't have the movies. But how we checked this to make sure that we had the whole appendage is the lumen of the balloon catheter, you can inject it. So you could see the remnants of it, and here's the upper part, and here's that whole bottom part. And, you know, it shows a little better here, but we actually had it filled. But like I said, I couldn't grab the cines. This was actually from an iPhone, taking pictures so I can get it. So, the things we do for you, DJ.
Thank you.
Yeah. So what we did is we actually injected here to make sure we captured, and then we injected from the outside to make sure we had everything, and you can see we had it.
Did you decompress it?
No, I didn't.
Decompression technique?
No, I didn't.
It actually helps
decompress
quite a
it.
bit oftentimes. And this is something that we've been
You
doing
can.
quite a bit
Yeah.
when we have these crazy lobes. So
Mhm.
once you get that little balloon catheter in, you're not deployed your suture yet. At that point, if you suck back all the blood that's in the thing,
It's
appendage
easier.
actually shrinks.
Mhm.
And then moving it further down or getting it off of the appendage becomes a lot easier.
Right. But you can see here where we closed down on, and, you know, I don't remember if you remember the initial angiogram, there was this up part. Remember how I said I was concerned we wouldn't get off? We opened this up and we actually did have trouble coming off. And what we did is we pushed the soft sheath all the way up to a point right about here. And what that does is it lifts the whole thing superiorly. And we were able, instead of pulling down, we were able to pull outward, and it came right off. So
you pull the soft catheter.
yeah, you push the soft catheter all the way up to give you some superior lift.
And in fact, that's exactly what we did yesterday's case.
Yeah, the epicardial sheath. And that lifts this whole thing upwards, and then the direction of this goes this way versus downward.
The endocardial.
No, the epicardial. Epicardial, you use that as a support to push it upward.
I mean, especially when it is superiorly oriented or very anterior, that maneuver actually works very well in
Yeah.
almost all the cases.
Yeah, I mean, if you ever have problems, it works very well.
Great,
All right.
very nice. Any questions on this particular case? So with this, I think what we'll do is we'll open up for panel discussion. We have another 20 minutes for us to quickly take a few questions. I mean, anything that you want to, I mean, you have questions about in the last 2 days of stuff that we have presented. Let's do that. If there are no questions, then we'll probably talk about, some of the things. Well, obviously, we did a fantastic job teaching what all little we knew. So, I mean, I think for discussion's sake, what do we do with these appendages that internally measure 45 millimeters, 42 millimeters? I mean, I think on average, it seems to be in Kansas and Missouri, our appendages seem to be a lot bigger than the other appendages you guys talk about. I mean, majority of our cases come on with 43 millimeters, 42 millimeters of appendages. So, I mean, how do you really deal with those cases? I mean, whether it's a true indication, I mean, of course, we can use lariat, I mean, yeah, stating the compassionate use of it, and oftentimes, decompression, you can always get it tied off. But there are cases that are not amenable for lariat ligation because of their orientation, shape, and other reasons.
Oh, you mean you can't do it endovascular because it's too
Endovascular
large?
device, yeah.
Well, I've been doing Watchman since 2006. And I've only had one patient excluded where the mouth of the appendage was greater than 30. One. I don't think it's not very common to see the mouth of the appendage to be greater than 45. You'll have the body of the appendage larger, but usually the neck is very rarely above 30, 33. Very rare.
Yeah, since 2007, we've done maybe 4 or 5 size 33. So those were generally less than 3 centimeter appendages.
So usually the
We've
neck
had-
of it is very rare to be.
Very rare to be that
Greater
large.
than 33.
But we've excluded people for too small an appendage, and there's no room.
To put
Maybe
a device in.
ACP would have been better there.
Then how do we really determine, I mean, this $1 million question of what is the approximate site of ligation for what is the best site of ligation or device deployment from a thrombogenicity standpoint and from an arrhythmogenicity standpoint. I mean, we do understand that the pectinate ridge that happens just immediately after the neck is the most arrhythmogenic aspect of the appendage. And I mean, some people argue that the neck is relatively smooth, and so the relative thrombogenicity is lower. On the other hand, the problem with a ligation device like Latitude is that, I mean, the more basal you try to go to get, the more tissue that you try to get. And then the unfurling effect with the motion of the heart can create a central leak that we come across. So in an attempt to get more tissue, more tighter closure, are you compromising the closure in the long term and causing a central leak instead of pinching it off of the neck? Any comments on that from the experts?
I mean, for us, I mean, when we do endovascular devices, when I do both, I mean, endovascular devices, we don't go to the neck. We don't put the device, face the device at the neck. We leave the smooth part uncovered. We just, because embryologically, the atrial appendage is the trabeculated part. And the smooth part is the incorporation of the pulmonary veins, right? And embryologically, that's what the atrium is, embryologically. So we don't think that that's the atrial appendage to start with. And so I think that's what you do, isn't it? Deeper device. And I've never seen an issue of thrombus formation. The only few cases I've had thrombus is when a patient did not take Coumadin in the first 45 days, or like your case, a late case or something like that, but not
on the
Yeah. So, I mean, sorry.
I don't think there is any, you know, to be honest, I don't think there is any data to say that it's unsafe. We try to put the watchman, you know, proximally, but, you know, there are cases where, you know, you leave a little bit of sort of a smooth portion, and, you know, I agree. I mean, we haven't seen, I don't think that's a major issue, because otherwise we would have found out.
Otherwise it would have been much higher.
Yeah, yeah.
With sample, we've always tried to recapture and pull it back and get a flush device. I mean, we have
Not just to cover
the
circumference.
yeah. So basically flush from one side, yeah.
Yes.
Where you can't go the other side, because then you get a shoulder on the other side. I mean, so
For example-
generally the bias is to, some shoulder is okay to cover the whole thing.
For example, you know, if you are not here, but, you know, I ask sort of many cases that I see of atrial clip that come for ablation. The clip is always distal, it's not proximal.
Exactly.
So they leave a significant portion of the antrum where you can actually place a circular catheter, so it's not small. And those patients, you know, once they are cured, because the distal part is closed, the trabeculated part is closed, we took them off Coumadin, they've done okay. So, I mean, that's not, you know, several hundred patients, but, you know, I mean, if there was an important issue, we would have sort of find out that, you know, the patient a problem. And I think most of the surgeons actually, they don't put the clip very, very proximal, despite, you know, they should do that apparently, because I asked the question when they show the movie, it looks like they were coming proximal, but in the cases that I've seen, it's almost never proximal. I mean, and there is a significant portion of smooth antrum that is open. So I don't think we have good data, but anecdotally, I would say I don't think it's a big problem.
You know, I think I would agree with everybody that if you take out the trabeculated area and just leave the smooth part, which is usually the neck, you're probably okay. However, the caveat here is I think we've been poisoned a little bit by the surgical literature, you know, in terms of 1 centimeter diverticulum increased thrombus formation. The real question there is what is that diverticulum? And was it actually smooth tissue, or was it really 1 centimeter of trabeculated? And I think you're right. It's this era now where we're doing these that we have to start looking at this, because I think DJ is right. I think like say with any epicardial approach, the lariat or any epicardial approach, the closer you get to the atrium, the potential, you know, for the tissue to push the suture back is there.
Mm-hmm.
You know, because it's just more pressure.
I mean, it's more tissue. It's almost like you're taking a bunch of parts, and it has to unfurl over a period of time.
Right.
So with that question, I mean, I think uniformly we all agree that in bulk of the cases, the neck is smooth. But I mean, if you look at some of the anatomic specimens, the trabeculated, the fenestrated portions, actually sometimes you can see that on the neck and extends onto the atrial body.
Right.
So these are the diverticulate. So those are the cases where I think there's not a whole lot you can do. I think you have to individualize the care for each of these cases.
So the biggest thing is you can't have the device dislodged, so you have to have good compression. So you can only have that much of neck and that much of shoulder. So whenever I leave too much of shoulder, I'm not happy.
You're more nervous.
And
Yeah,
also, the more
dislodgement.
proximal you put a device in, it's in the smooth part, it won't even anchor. The best anchoring of the device is in the traffic part, so you need to be a little bit deeper.
Any comments on the type of leaks that you see with the Amplatzer device? Because everybody talks a lot about the differential remodeling around the device.
Actually, I have a question for Sable. In Europe, I don't have experience with the Amplatzer in the same. In Europe, I've done some, and I talked to people that have done, and some of the complications that they talked to me about, we never saw it with Watchman, like compression of the circumflex.
Yes.
So is that something that unique to that device? Can you comment?
Did they tell you that?
Yeah.
Okay. So, I have an abstract which has just got accepted, on this. The thing is that the disk of the device, if it is too proximal and too large, can potentially even go and impinge on the circumflex or the mitral valve. So there's actually potential of mitral valve. So that's why you have to be very careful, because remember that lobe, and then there's a disc which is larger, and the inferior edge of the disc can actually go near the mitral valve. So you have to, when you're replacing the Amplatzer device, you have to make sure that the inferior disc is not too proximal and is not going towards the ring. So that is one potential chance of ACP in that.
So do you try to image the circumflex with that device when you place it?
Well,
Because-
you can see you don't do a contrast angiography.
No, I mean, with the
But
with
the echo,
TV.
you can see
Yeah.
where it is, right?
So you try to check, make sure you're not compressing.
No.
Okay,
The left side.
yeah.
But they did say that they had an issue, right?
Yeah, especially, I don't know with the new, but with the older device, absolutely, yes. Definitely. Yeah.
So Cyber with the okay.
Yeah, go ahead. Oh, they're just
Yeah,
getting to the next.
So,
Go ahead.
yeah, the Watchman thing, there's been a bias to oversize and oversize and oversize. Have you been doing that too?
Yeah, I know, because to prevent, the interesting part of the Watchman device is that if you oversize more than it should be, you don't get penalized. I mean, nothing bad really happened. If you undersize, on the other hand, it comes up, because it can compress quite well. So what we believe is that the best way to do is to make multiple measurements, and whatever measurement you get, you add I just add 4 millimeters to that maximum. So if I measure 2 as 20, 25, or 125, I just add 4 to that and see what is the device closest to that 4. So now it's 29, so I would use a 30 device. If it was, say, 26, I'd use a 27 device. And so I slightly oversize.
Size it a little bit.
Yeah, because, I mean,
We
that
do too.
helps with osteal closure, and then basically, we have dramatically reduced our usage of devices, because
Exactly.
we would partial recapture and bring it back a little bit and get away with it.
And then also the leaks, you get reduced chance of
Okay,
leaks
yeah,
also.
Yeah,
We
you
use
get a
the-
little shoulder, and you've covered the whole thing.
Yeah.
I think a little shoulder is, you know what, I want to understand what he means by shoulder. Shoulder means like, say this is the ostium, and you have a device like this, and a shoulder means something sticking out like that. So it's like a cork, right? So 50% of the device is covered with material, and the lower 50% is not. So if you have more than 50% of the device sticking out, then there'll be a leak. But if more than 50% is inside and a little bit is sticking out like a cork, it's okay. That's what he's trying to say.
Push the cork in a little more.
Yeah, that's all. So if you have a little bit of a shoulder sticking out, it's fine. It doesn't have to be flush.
Excellent. So with this, I think we'll probably try to wrap up, and one final word. We thank all the contributors, Boston Scientific and St. Jude Medical, who contributed at the gold level, Center Heart and AtriCure, who contributed at the bronze level, and then all our exhibitors that are listed out on the things. We thank you all for such wonderful support and the sponsorship, and we thank you all for taking 2 days of your valuable time to come and spend with us to learn more about this exciting science about left atrial appendage. Hopefully you had a good time, and I mean, understanding some of these new concepts. And it's amazing that how much new information that I learned in the last 2 days. Again, please complete your evaluation forms that are there on the table, and either leave them on table or registration desk where we checked in. One thing about the World Atrial Fibrillation Awareness Day, it's going to be September 14th this year. So if this is something that you're interested in organizing in your hometown, please let us know. Donita Atkins would be more than happy to assist you to get it organized. And we proudly announce the second edition of the International Symposium on Left Atrial Appendage, 2014, March 7th and 8th, most likely. This is contingent to any other potential conflicts with the major symposia around the country. And we also announced the Kansas City Heart Rhythm Symposium on August 17th and 18th. So this is more of a regional symposium. We'll look forward to seeing some of you there. Before we end, I would like to have the co-directors to give away our appreciation to the core team, which actually made this entire thing happen. So I would invite Donita Atkins to come to the podium to get the key personnel award who really made this symposium happen. I think if not for her, we will not be here doing what we're doing now. So I would like to have Andrea give away her plaque. I also invite Julie Darrington to come to the podium, as well as Marla Sutton. Julie, Marla, they're all hiding someplace. And then Caroline and Missy too, please.
We don't have them.
So I once again thank you all on behalf of the co-directors, and thank you all the speakers. We will see you in 2014.
Mr. What is your last name?